Professor Sir and distinguished audience and speakers for giving me an opportunity to speak out of turn. I was given actually two topics, when not to operate a squint and to do squint resurgery. Now, since I'm speaking in a room full of strabismologists, I think, well, we all know this, that when there is a varying degree of strabismus or when the strabismus is of a recent onset, it is always better to wait and, retake the readings after 3 months. An intermittent exotropia, because if the Newcastle score is less, if the stereopsis is good, we have seen that early intervention can lead to a subsequent esotropia. All of us have come across patients who are operated pretty early in life to preserve their binocularity, but if it is intermittent, the binocularity is preserved as it is. Of course, medically unfit patients, as surgeons, we are very enthusiastic in doing surgery, and for cataract surgery, we can, disregard the fitness that much, but that's not the case, especially when thyroid levels are varying. In neurological cases of strabismus, when it is of a recent onset, when it is associated with a stroke, it is always better to wait. Again, a recent non-concomitant strabismus, it is better to wait. Similarly, for microtropias, or this is what we always tell our students, when there is no strabismus in the primary position, we know there are exceptions like the Duans, the Browns, or the primary inferior oblique overaction. But generally, if there is no strabismus in the primary position, do not operate. Even recent consecutive strabismus, unless it's a lost muscle or a slipped muscle, which must be tackled immediately, but if it is a ET after a XT surgery or a XT after a ET surgery, then it is prudent to wait for a few months before reconsidering surgery. Again, if there is a large overcorrection, there is a Cooper dictum to plan and execute the second surgery as if the patient has never had previous surgery. Again, for a treatment of overcorrection, well, do not reverse the original surgery if ET has become XT. Do not undo the recess, but rather you tackle the other eye and do a recess. If the overcorrection is just less than 10 prism diopters, peripheral fusion takes place, and a smaller overcorrection leads to faster reappearance of a normal retinal correspondence. So it's not that bad. Again, of course, if it is an overcorrection which is more than 12 to prism diopters, we will have to tackle it. And if it has happened immediately in a post-op period, if we suspect a slipped or a lost muscle, then of course early intervention is beneficial. The sooner the better. But one of the things we have to understand while doing resurgery is that the dose-response relationship is difficult to predict. So this is where adjustable sutures are a great help. But of course, they need skill and patience on part of the surgeon and faith and cooperation on part of the patient, because we have to tell the patient that even they will have to cooperate to it, and we don't have a very easy, clear-cut answer to what they have. And of course, adjustable suture improve the chances of good outcome, as was seen in a study by Repka in the US. But in our setting in India, the problem is they need a short general anesthesia for children and for uncooperative adults. And the adjustment has to be done on a second post-op day. And a lot of us run extremely busy OPD. So doing one surgery is itself for this, because there are surgeons who do 10, 12 surgeries a day. If it's an adjustable, then each surgery then has become a 2-step procedure and has to be done over the second day. And in a lot of medical schools, institutes who have alternate OPD, OT, even that has to be factored in. Perhaps that may be the reason why this procedure has not become that popular in India, even though, of course, it gives much better result. And there is a RCT from GNSC Delhi which shows that perhaps there is no significant difference as far as adjustable suture is concerned. But there is another RCT from KGMC Lucknow which found that modified adjustable suture is more predictable. It definitely is predictable, but then perhaps some of our strabismologists are already so predictable in their outcome that they feel that we don't need a adjustable suture surgery. But then for thyroid related strabismus, yes, we could need it. And the main pitfall of course, when we are planning a resurgery is that the normal anatomy is disturbed, and identifying the muscle needs experience, skill, and patience. And we have to be prepared for surprises. So this is something that is there. even when it's a restrictive strabismus surgery or surgery after a trauma, because again the normal anatomy is not there. And this is my personal this, if in doubt, it is better to grade the surgery. But in the morning only, Professor Pandey sir was telling us, no, it is better if we do both eyes together and to tackle one or two muscles at a time rather than attempting multiple resurgeries. So thank you to the AIOS Scientific Committee for giving me this opportunity.